Great. We also have a question on the screen here about subcision technique. Do you ever use subcision? Because obviously you described the anatomy here with the septum and so on. And that could theoretically be something you address with the subcision and then perhaps putting some filler after subcision. Do you ever use that combined with your filler?
As surgeon, as anatomist, I don't believe in cutting the septum if you don't perform surgery before. Because when you cut the septum, as in corrugate or in other areas of the face, and also after surgery, the scar recreates the septum first. Second thing is the septum is really thin, but is really strong. So cut it, and to do subcision, so to cut it can create a big hematomas. I did it my first time in my life when I performed my first lipostructure after I knew Coleman 20 years ago. And I have the biggest hematomas in the area I had in my life, never in my life. And after that, I stopped. Never I cut the septum. I put a fat or uric acid on one side or on the other side.
Perfect. Beatrice, we also have a question for you. Do you sort of consider for optimizing nasolabial fold treating the risorius muscle with toxine?
Usually risorius. I think most commonly we tend to treat the depressor oris where people turn the mouth a lot for the corners. I don't tend to do, I mean, often at all. It's not something I do. I'm not sure if anyone else does different, but, and like, I think what Dr. Solti was mentioning about the injections with, like for the nose, for the tip of the nose, then we do use toxin as well there. And obviously for gummy smiles, but not often. I don't think I feel it makes so much difference for the nasolabial fold.
Good. Also, I just want to add the issue to you, Sergio, about deceptions. I think deception is something we really have to look out for. You showed the picture from Instagram where somebody shows a picture that you basically can't achieve. First of all, the comment to that picture is that, is it even something we desire to completely obliterate the nasolabial fold? Some people in these pictures have a completely flat fold, and that's not even seen in children. So should we try to modify the way we treat it? The other question when it comes to deception is obviously photography, because I see very frequently in pictures, even sometimes by very experienced key opinion leader, that the lighting for the nasolabial fold is very different, and the lighting is super important when it comes to the appearance of the nasolabial fold. So how do you think we should address that to really have more optimal results? And should we aim for obliteration of the fold, or should we try to get people to understand it's natural to have a little bit of a fold?
I think that social media is really a problematic issue that is growing and growing, because I don't know in Europe, but here in Latin America, mostly half of the new consultations come from the media. So people is watching the Instagram every day and they come with this in mind. I know that the Instagram has a way to show before and after photograph, and there is some actions of the media, but we cannot wait so much about that. I think that all of us contribute a little bit to enforce the thing, because what we put usually to our media is our best cases. Usually, all of us, we don't select the moderate results or the bad results that sometimes we may have, but we put the best one. So every one of the doctors who run in aesthetic put the best results. Besides, more others, as you said, use the Photoshop, which is really, it's not good, absolutely. And it's like a criminal. And we know that the most follow accounts that have almost millions of followers, many of them have some problems because of not true publicity. But it's a problem that is growing, and I think that something should be done, because it's not enough what you can explain to the patient. The words cannot replace the image the patient has in its mind. So I think that we are facing a problem. I don't know also there, but here we have every day more patients complaining. Every day more and more patients want to go to to a point that is very difficult to reach with our job. So I think it's something growing, and I think in the next congresses we will have roundtables and so to speak about that, because when you consult all of the doctors, they have some problems with people not demanding as a judicial form, but complaining. I want more, a little bit more. I want more. It's not enough. This is something we are facing more with the anxiety of these years.
I agree with you. I mean, the issue of patient communication is a topic for a long workshop in itself, because patient communication is such an important part of what we do and how we achieve those realistic expectations. Giovanni, I would like you to answer also. You showed your injection into the pre-maxillary, zygomatic space, which I think it's important, but you said you put a very minute volume there. Do you ever inject larger volume in that space? And do you use multiple injection points? You didn't show how many areas you inject in the pre-zygomatic space.
Thank you for the question. As probably Fabio has shown in his pictures, this space is a very limited. It's a virtual space that you open with your product. So the amount very often is less than 0.3. Even because in this area, we don't want to have water attraction, because it will influence the lower lid. It is something that we don't want. So it's much better to inject a small amount, wait at least 1 month, 2 months, and then re-inject in case of need, because this area is very rewarding, and very often HA will attract water over time. And so we want that the water attraction works on our side. So I under inject like 60 to 70%. I wait for about 30% coming from a little bit of swelling. So in that way, I have 100% correction. If I inject 100% from the beginning, very often I over inject at the end, because I will have water attraction. So I do believe that being limited in the amount of volume that we put in this deep space is very important.
But don't you also feel that when you inject in the pre-zygomatic area, that the risks are much less than compared to injecting superficial? Because obviously much of the malar wound problem is superficial injection, where the swelling of these products is horrible many times.
Yes, of course. As long as you inject deep onto the bone, you are quite safe, because the distance to the skin is quite important. So the deep injection is safe as long as you stay in that area, as you said. But I always prefer to be conservative. So of course, if you need a volume in the midface, very often you need at least 1 ml per side. But I prefer to give my patients less of the full dose, and then I re-inject after 1 month, because this makes things easier and very often safer.
I think obviously what this addresses is obviously one of the problems with fillers, and that's the way they're hygroscopic and attract water, and this is problematic obviously in the periorbital area. I think, however, there is indication that the next generation of HA fillers that are not on the market yet, but new ideas related to, don't have any swelling at all, basically, compared to other products. So that would be wonderful for us in the future to have these products that doesn't give any swelling. We know what we give is what we get, and that's obviously what.
When all the sites are saturated before the product is going to the market, we are going to have product without water attraction. That of course it's very good for the periocular area. But in the midface, there are some products that are designed to swell a little bit, So it's better to wait about 1 month to see how much it will improve and how much it will grow.
True. I think another issue that perhaps all of you would like to comment on, or anybody, is the question about we lecture and speak about using cannulas to be safe, which is obviously much safer than needles. But the question is, can we teach people to use cannulas to make them feel safe, because I've shown in dissections how you can penetrate the artery with enough force with the cannula, even though it's 25 gauge. So the question is, knowing anatomy is the most important, and then the technique of injection, but how sure can we be that it's safe to inject with the cannula? Fabio, what would be your comment to that?
My comment is, as Arabians say, is inshallah when we inject. No, I don't want to joke. No, the thing are two. For me, is knowing the anatomy. We know where there is where we have a high probability to find vessels. The second thing is surely if we force a 25 or 27 gauge cannula can penetrate a vessel, but you have to penetrate it, so you have to do it expressly. If you go slowly, my cannula when penetrate, I always say in the course and in the dissection course that I do, I always say the cannula has to penetrate as a snake into the fat. So he has to penetrate us into the butter. If you feel it, that a easy penetration, it means that your layer is correct. If you feel something difficult to be penetrated, if you know perfectly the anatomy, it can be a septum. So if you know that in that area you have the septum, you can penetrate it because it is a septum. Otherwise, your layer of or penetration of the cannula is not correct. You are too much deep, you are touching a muscle. But in this case, the patient feeling is a little bit painful. Or you are penetrating a vessel, because it's true that you also using a cannula, you can have an hematoma if you force and you traumatize the cannula. It's not only the tool that you use that create a safe technique of injection, it's the tool and the way you use it. So with a delicate movement and slowly penetration, generally there is no problem with the vessels.
True, good. Another issue, obviously, that this type of webinar raises is the right treatment amount for nasolabial fold. And I think all of us agreed, and there were a lot of comments on it, that this may be what patients ask for, but perhaps it's not what the patient should have. Have we overtreated the nasolabial before? Have we started to go away from it? Do we overtreat the midface today in certain patients to really try to lift the face? What's your comment to that, Beatrice?
Absolutely. I think we started, like you say, over-treating, then we run away from it totally. And this is where I think now at the end of the day, patients need to come to us because you understand the facial anatomy and how to treat it and analyze the face. We are doing a little bit of an art with it. We need to make them look better but natural, and I think these days women do want that. And of course they do say, oh, I want to do this, but they don't understand the consequences of treating just one area. And this is where working with the whole facial anatomy as is a puzzle, and getting, like, you know, all my colleagues have agreed, treating areas where it's more neat. And if you explain it to the patients, I do believe they do listen. And if they don't agree with you, of course, then maybe it's not the right patient for you, because you don't want to be treating something you don't believe is going to create a good aesthetic result.
Sure. I mean, obviously, the perfect aesthetic treatment is the one you don't see. So artificial, strange appearance. And I sometimes think I see all of these overtreated mid-faces in an attempt to lift the face. Would you agree on that, Giovanni, or how do you try to balance your communication with the patient related to their request for nasolabial fold or excessive mid-face treatment?
I totally agree with all of you. And of course, I think it's very important that we work on education of patients, and especially that, like Sergio said, Instagram, it's a way of diffusion of terrible treatments and a lot of fakes and a lot of photoshops. So it's important that we assess a face, we share a strategy with our patients, we educate our patients on our strategy, and we approach the face, like Fabio said, from the foundation and then coming to refinements. So I totally agree. I do nasolabial and lips like my last treatment when all the rest is done, and then you can approach those areas that usually are the first request from ladies. I want to treat my nasolabial, I want to treat my lips. So if you agree, we reverse the strategy and begin from on the other side and go to that as the last treatment.
Yeah, no, I think that's a wise strategy in these situations. Sergio, could you also just comment on the fast, the cadaver-like face, how expensive it is? Can reuse? Do you think it's something that could be applicable only for early beginners? What is the difference compared to cadaver dissection? Obviously, cadaver is not available for everybody, but what do you think is the future for this?
I think, well, we are working on this with Dr. Asher, and I think that it will come times where the initial doctors will go at the beginning through simulators. Probably you and all of us, we have done many courses, and we see the young doctors, their hands trembling in front of their first injections. So we try to develop something that could be an intermediate between the theory and the first injection. So this is the first position of the fast, linked to this type of hyper-realistic simulators. Of course, it's not anatomy. It's just a resemble of anatomy with the main things to help and to make easier and affordable for the people who may or may not have its own simulator. We are developing centers where you can go, learn, and then go to the patient. This is a little bit the idea that I think that in initial for the beginners, but maybe for a new technique when a new product appear. For example, there appeared the polylactic acid. So you have a new technique. Well, where do you practice it before going to a patient? Okay, there is something where you can experiment, where you can inject wherever, and you can have lessons about how to do it right. Then you have done it 10 times, then you can go to the real patients and be more accurate and more sure and have less side effect. This is the aim of this development.
Right. One thing related to anatomy that I think would be worthwhile commenting on, the great variability in the nasolabial fold, how it relates to the muscles. We know a patient with facial paralysis loses their nasolabial fold. Obviously, the question is, why do some people have so deep crease? Do they have much more muscle fibers running into the septum? Why are other people so blunt in this area? There is great variability in the appearance of the fold, even in relatively young people. And you mentioned that you didn't really treat the nasolabial fold as a primary treatment, but I see sometimes these people with really clear creases in the periorbital area. And for me, it seems like a very good indication even in young patients. But those are unusual cases, but it has to be individualized though. Could you comment on the variability there? Fabio?
Yes. In some patients, both retraction and hypertonus of the levator labii superior and levator labii superior lacrimal acid can increase the depth of the upper portion of the nasolabial fold. All we know is that when we want to treat the gummy smile, we have to treat both muscles and at the same time also the deep layer of the orbicularis oris muscle in the upper lip. But treating the gummy smile, also the upper portion of the nasolabial fold improve. It is because both insertion of both muscles are fixed to the skin at the level of the nasolabial fold before and in the upper portion of the perioral area. So during the aging process, as into the glabellar area for the corrugator muscles, the increasing of the tonus and the contraction, the hypertonus of the elevator muscle can increase the nasolabial fold. It's not the first indication to treat the muscle with botulinum toxin, but it can be a second possibility or a synergic treatment to improve the area in people, in patients with a particular hypertonic muscles.
Also, another question that perhaps could be answered by Sergio, also related to problems and complications if you have irregularities and unnatural firmness in the nasolabial fold. How would you treat that? You can start to answer, Fabio, and then perhaps Sergio could comment also.
Yeah. Okay, the small superficial irregularities. If these irregularities are in the nasolabial fold and the upper perioral area, I prefer to use really low density hyaluronic acid using really thin cannulas, 27 gauge cannula, and I create as a thin layer subcutaneously of hyaluronic acid to recreate, also because of the hydrophilicity of the hyaluronic acid, to recreate a smoother appearance of the upper lip and the perioral area. When the irregularities are in charge of the skin, it's more difficult. So be careful when you inject into the deep dermis. You must inject really small boluses. 0.05 is nothing. When I want to do this kind of treatment, I use really low density hyaluronic acid or not reticulated hyaluronic acid to treat the dermis. Otherwise, you risk irregularities that the patient will maintain it for many months.
And you always use multiple puncture technique when you treat intradermally instead of a linear threading?
Yeah, because I prefer that the tip of my needle penetrate for only 2 millimeters of the skin. I don't like that the needle penetrate for all its length into the dermis. I want in this case, my concept is I want to disrupt the fracture, injecting small boluses. But I generally use small syringes also. I use the insulin syringes when I want to do this kind of injection, because using the small syringes is not allowed by the companies, but you can inject really small amount, as Dr. Wayne Carey did in the last 10 years.
Dr. Eden,
Yeah.
we're ready to close if we can. Do you have a final conclusion and then I'll take over for the next announcements.
Yeah, the final conclusion of this nice webinar is that obviously we have many questions still remaining. I have a list of things that I would like to discuss with all of you, and unfortunately we don't have the time to speak any longer because there is more to come after this. But I really want to thank you all for your expertise and for sharing all of the interesting comments you have had and valuable tips for all people listening. Thank you so much for this webinar. It was wonderful to be part of it and listen to what you had to say. Have a wonderful evening.
Well, thank you, Dr. Eden. Thank you to all the experts. It's been, as you say, very informative and instructive. We could go for hours. There's been a heated comments in the chat box. Almost 1,000 connected today from all over the world, from Canada, Israel, India, Bahrain, United States, Argentina. So thank you everyone for being with us today. So if you want to join us on the next webinar, which is actually really relevant for this topic as well, to improve your anatomy, we're going to have next Wednesday, June 16th Also, Dr. Sergio Escobar will be with us with his simulator and the FAST methods. So we are going to be talking about the future of anatomy with the innovative tools that are coming in the market to study the anatomy and have a better look behind the skin, so we can avoid complications and improve our techniques. So that's, we invite you to join. You can register here in the webinar page in IMCAS Academy. And also we want to invite you to join in July 15th to 17th. There is a cutting edge virtual class. This class is composed of live dissections, live injections, and the innovative thing of this class is that as I am speaking with Dr. Pereden, all of the participants that join this class are able to speak one-to-one with the trainers and ask directly their questions. There will be Dr. Asher and Professor Cotofana are the directives of this course, and of course wonderful dissectors and injectors ready to answer all of your questions live. You can join this class in www.thinking.fr. So you can register and see the full program of the 3 days. It's 5 hours per day. Everything is live, and there is a full training on anatomy for injectables and threads. Also, echography is integrated as well as 3D devices. We also want to invite you to July 10 and 11. It's IMCAS Asia. It's another edition of our Congress in Asia, which unfortunately this year will be happening as well online. Unless you are in Shanghai, you have the possibility to be physically. There will be 2 rooms in Shanghai where you can attend physically if you're there. If not, you can join from all over the world online with the classical IMCAS themes. All of the topics in aesthetics are included in this conference, and you can join here at imcas.com. And that's it. It's a wrap for today. We hope you can join us in the future. We want to thank the expert trainers for their knowledge. We want to thank the wonderful IMCAS Academy team for the logistics and AV that make this webinar possible. And of course, our grantor, IBSA, and our scientific collaborator, ICPE. So have a good day or a good morning or good night to everyone.